BSI is my scene safe. I would check to see if it's a MOI or NOI, my number of patients, any additional resources if my patient needs C-spine. Then I would go into general impression. I would be checking age, sex, CT, LOC, CTC, sick or not sick, distress or not distress, and any major bleeds and position. In this case, my patient is about 22 years old, of East Indian descent, does not appear to be in any distress, does not appear to be sick, is in a sitting position, and does not show any major bleeds. I will then check my patient's level of consciousness using ALPFLU. My patient is alert because she notices me as I approach her. Then I will check my patient's orientation. Hi, good day, ma'am. I'm John Abram from the ambulance service. What is your name?
Judah.
How would you like me to call you?
Judah.
What time of day it is?
It's nighttime.
What were you doing before you called the ambulance service?
I was eating.
Then I would go into airway. I would check my patient's airway, making sure it's open, clear, and maintained. I would either ask my patient to open her mouth, or I would manually open her mouth using a head tilt chin lift or a jaw thrust. And make sure my patient's airway is clear by either suction, or I'll ask my patient to simply remove the contents. I would maintain my patient's airway either using an NPA or OPA, or if it is simply self-maintained. Now then ask the questions, is my patient breathing and how adequate? I will check adequacy using SOI PASO, SB and SPO2, my pulse oximetry meter. Then I will inspect looking for tracheal deviation, jugular vein distension, decap BTLS. Then I will go into oxygen, whether my patient needs an NRB or BVM. Then I will palpate looking for tracheal deviation, jugular vein distension, decap BTLS, and subcutaneous emphysema coming across the clavicle and then coming down the middle in praying hands, and then feeling for tidal volume. I would then auscultate on the 4 points, mid-clavicle left and right, and then mid-axillary left and right. I will then see if my patient has any sucking chest wounds, any punctures, any penetrations. Then I would reevaluate my patient's SpO2 using the pulse oximetry meter. Then I will check circulation, pulse scan and breathing, pulse checking the rate, rhythm or quality, whether it is fast or slow, strong or weak, regular or irregular. I will check my patient's skin using CTC, color, temperature, and condition. I will then check bleeding in my patient, whether it is obvious, hidden. I will check the voice in hidden. And then internal, I will ask my patient, ma'am, have you seen any blood in your vomitus? Have you seen any blood in your stool or your urine? Then I would go into disabilities, which would be my Glasgow Coma scale, and checking my patient pupils using Pearl. Then I would expose whether my patient needs to be undressed or treated for uncontrollable bleeding or treat for shock. Then I would make my transport decision, whether to stay and play or load and go. After my transport decision, I would then take history. I would use my OPQRS or my sample or my help. Then after my history taken, I would go into vital signs. I will be taking my patient's blood pressure, respiratory rate, pulse, SpO2, skin temperature, capillary refill, glucose, Glasgow Coma scale. Then I would be doing a physical exam once again, whether I will do a focused body scan or a rapid body scan. Then I will go to my clinical impression, which is COPS, whether my patient is critical, unstable, potentially unstable, or stable. Then I will go into my interventions, which is power bomb, which is position, whether on the injury to my patient, if it has a position of comfort or a position she has to be in. I would then go into oxygen if my patient needs if my patient needs an NPA or OPA. W, which is warm, if my patient needs to be treated for shock. B, which stands for bandage or splinting, if my patient has an injury that needs to be maintain, I would choose the appropriate splinting to splint my patient and then check PMS, which is pulse, motor, and sensory. I would then check A, which is advanced airway if my patient needs ALS, and M, medication if my patient is on any medication, if she needs any medication such as active charcoal or EpiPen, etc. After interventions, I will then go into transport decision. Once again, I will then reevaluate my transport decision if I want to stay with the same transport decision depending on my patient's condition at this point. Then I would recheck my patient's ABC, vital signs, interventions, impressions, her CC, her LOC, and her CTC. Then I would have reached disposal where I will hand over my patient to the hospital when I have arrived. I will tell them my patient, if my patient has either had a nature of illness or a mechanism of injury, I will tell them my patient's injuries and interventions, give them my patient's signs and symptoms, and then the treatment I gave to my patient.